Hello, welcome to William Harvey Hospital. We know that joining a new department in an unfamiliar environment can be a daunting experience, so we've made this short video with some essential information so that you can hit the ground running. As a doctor in training, when you join the organisation, whether you're here as a GP doctor in training or an ST core doctor in training within the Obs and Gynae programme or a foundation doctor, you will undertake a corporate organisational induction, and then you will have a site-specific departmental induction which will cover things that are very specific to our department and things that equipment that you may not have experienced or used elsewhere in your training to this date. And then you will go on to have a specific maternity induction, and the reason that we have that is because we deliver it with midwives, because multi-professional training we know improves the quality of care for women. If you are a GP or foundation doctor in training and you'll be with us for a shorter period of time, then within your induction you will undertake a core clinical skills training day with our midwives and sometimes our support workers. So again, it's multi-professional. During that course you will get exposure and experience in human factors and simulation within a maternity and emergency gynae setting. The purpose of all of this initial training, which you'll get over the first few weeks that you're with us, is to set you up to be successful and to get as much training opportunity within when you go into the clinical environment as we can. So, for example, if we know that lots of you will have not undertaken fetal physiological training before in other maternity units or settings that you'll have worked in, but we use that here. So it's really important that you get that training early on so that then when you go into the working environment, staff are using that language and you will seamlessly blend into that. Before you arrive in the department, you will have had a copy of the rolling roster, so hopefully you will be able to plan ahead to understand when you are on call, including your weekends and nights. However, when you arrive in the department, we will show you an example of a weekly roster which will come out to you every Friday. On that, your daily duties for the following week will be assigned, and we will talk you through what that timetable looks like, an example of what that timetable looks like when you arrive with us in the department. The department actively encourages you to take study leave for your own professional development. However, we would ask that you liaise with our administrative and roster teams as early as possible, including even before you've arrived in the department, so that we can maximise the opportunity for you to be able to attend that leave. And the same goes for your annual leave, so the earlier you can tell us, the earlier that we can try and facilitate that, and we will always try and do so. The vision within our department is that we learn together to work better together on the shop floor. So the key to that is for us as clinicians and doctors to work really seamlessly with our midwifery colleagues and the wider team, so our anaesthetic colleagues, theatre colleagues, maternity support worker colleagues, and all of the other teams that support us, all to achieve a fantastic outcome for mother and baby and those families that we're supporting.
Midwives are lovely. They will help you and support you and guide you and work together with you. So generally on a shift you will have a Band 7 coordinator who is your go-to person. They are coordinating the shift. They will have an overview of everything that's happening, but their bread and butter of the day is to be on labour ward and look at the labour ward board. It might be quite different for you to be working with midwives. You might have been used to working with nurses before. Midwives are more autonomous in their practice, so they are decision makers. They can start a lot of treatments for women which you might not be used to, but midwives equally will work with you. We work together really well as a team. We welcome you as part of the team, and we respect each other's opinions. We work together really nice to get the best outcome of care for the women.
They're very capable and competent to make independent decisions. They will often do that and then present the case to you for you to then evaluate it. It's important at that point that you don't feel that the midwife is telling you what to do, but rather complementing your work. and that you then can feel empowered to also say to the midwife, based on your experience and skills, you feel that the history is different, or you've reevaluated the management, and you're now going to discuss that with the consultant or the registrar. And that way, we really work together rather than feeling like one specialty or profession has undermined the other.
We are a fairly busy unit. We have roughly about 4,000 deliveries a year, and that breaks down into about a 35% section rate, 30 to 35%. So the minute detail of that is roughly between 10 and 15 babies a day. It's very unpredictable, the workload. So although you come in for handover and you've kind of got a sense of what's going to happen, it's fast moving, it's ever changing, and you're dealing with whatever comes up at the time. When a midwife graduates, she spends a year being a junior midwife or a band 5, and then after about a year to 18 months she will become a band 6 midwife. So the majority of our midwives here are band 6 midwives. And there may also be some band 7 midwives on the shift as well, but the person in charge will have introduced themselves at the handover, so she'll introduce herself to you as the coordinator of the shift. We also have ward managers. They are band 7 midwives. So I've got a ward manager on the postnatal ward, it's the antenatal and postnatal ward, one on the labour ward, one on maternity daycare, and one on the midwife-led unit. So they are not always there, but they are managing those areas. So if you have a problem in those areas, your go-to person is your ward manager. And then there will be band 6 or band 5 midwives on the MLU, and there'll be band 6 or band 5 midwives on maternity daycare. Also within that team there's maternity care assistants, so they're band 2s, but they help us out taking observations, they can take blood, they change beds and do things like that for the women. Folkestone ward is our antenatal and postnatal ward, and part of your role will be to come and review the antenatal women that are inpatients with us. They can be admitted for a variety of different reasons, and you would come over to Folkestone ward and the midwives would direct you who you would need to see. Seeing an antenatal woman would mean that you would take a history from her, you may need to order some bloods or some scans, but you wouldn't, as a foundation or as a GP trainee or an ST 1 to 2, you wouldn't be making those decisions solely on your own, you would be referring to your registrar or your consultant. Also on Folkestone ward we have our postnatal women. They are newly delivered and are really in a process of going home, most of them. So your fundamental role in that really is to review women and to write in their notes, but also to make sure that the things are recorded electronically on our Euroking system. It's very important that when women are going home that we've written on there, and also to do their electronic discharge notifications and to make sure that their medications are prescribed, and the midwives will then give it to the women. Our maternity daycare department is a very busy environment. It's like the A&E for maternity. It's one area that you are responsible for, but sometimes it gets overlooked a little bit and you tend to go there last. But do bear in mind, women are sitting there waiting to be reviewed by a doctor. Women can come in when they're not suitable really to be seen on a labour ward. For example, they're not in labour, but they may have a problem. They may be bleeding or have reduced fetal movements and need to have some midwifery care and input, and also doctor's care and input. Again, once you've seen a woman on maternity daycare unit, her episode of care does need to be entered onto the Euroking electronic reporting system, so we can capture the work that's been done for that woman.
We have 2 units on Kennington ward. We have the gynae assessment unit and the early pregnancy unit. Both units are nurse-led. The gynae assessment unit is for urgent cases. We have a nurse sonographer in the gynae assessment unit. So anyone that you see in A&E that you feel urgently needs to come to the ward, and they can go through the gynae assessment unit. If you ring through, you might be able to get a scan that day or to be seen that day, if not usually by the next day. So the early pregnancy assessment unit is again a nurse-led unit, and they have appointment-only slots, and usually you would refer from A&E and they would ring the lady back the next day or the same day if they're there, and offer an appointment. There is a criteria, and if you go and speak to the early pregnancy nurse when you first come, she'll let you know what that is, and the same for the gynae assessment unit. So we can let you know what the criteria is and what matches and who's the appropriate person to refer to. It's really important, especially I find that with the ladies that are in with bleeding and pregnant, possible miscarriage, they're very emotional anyway, and so it's important not to promise them scans, times and dates, because unless you've checked with us first, because it's not always a scan the same day or the next day. They can be very upset when they don't get the scan they're expecting. You might need to talk to some of those ladies and counsel some of those ladies about miscarriage. The nurses on the ward can offer support with that, and it's probably a good idea to spend some time with the early pregnancy nurse and to gain some of those counselling skills.
So our handovers happen twice a day, once in the morning at 8 o'clock, where you have the incoming doctors, the outgoing doctors. We have theatres there and the anaesthetist as well, so we get a really good overview of the whole department. It's not just midwifery related. Gynae things will be discussed in that handover as well. We have a handover in the evening at 8 o'clock as well for the night shift. Also in the daytime we have a safety huddle which is at 1:30, and it will be the same kind of personnel, but also SCABU will be there, so we'll know what's going on with cot status in our special care baby unit.
My expectations of junior doctors is to be prompt and present at the handover at 8 o'clock in the morning. If they've got recent blood tests, blood results, then that's useful for us to know, because as labour ward coordinators, we can't know everything about every patient because often it's very, very busy. We do like to discuss, sometimes in depth, about patients who are high risk or we're particularly concerned about. It is useful at that point for us to know as much information as possible. We can then discuss it and escalate if we need to.
Maternity is a high risk area, and our number one thing is to keep everyone safe. You're dealing with emergencies going on concurrently, if you like. And the really important thing to do in those situations is to ask and to talk to each other and to communicate, because that's what keeps everyone safe. Those midwives that are on the shop floor, if you like, wouldn't necessarily know what grade of doctor you are. So if you're being asked by someone to do something that is outside of your remit or your area of responsibility or knowledge, then please do escalate to your registrar or to your consultant on call, because we don't necessarily understand how long you've been in training or where you've come from. You would escalate through the process of using a bleep. You yourself will be carrying a bleep, your registrar will carry a bleep, as will the consultant on call, and you will all have different numbers. We use the telephone system to bleep people. If it's an absolute emergency and we're having an obstetric hemorrhage, for example, or an obstetric emergency, you would use the 2222 system, which puts you straight through to the operator. You would state the emergency and then the appropriate response would come.
My expectation of the junior doctors is that they answer their bleeps promptly, because often it could be an emergency. Most emergency calls will go out as a 2222. However, sometimes we do need them to urgently attend, but not escalate it to that point. So it's good to keep in contact with the labour ward coordinator, because she will know what's going on exactly on the labour ward. Often we may escalate to our junior doctors if we're concerned about a patient's Muse score, so whether she's got high temperature or whether she's got high pulse rate. It's really important, if we think that these women are developing sepsis, that they get started on the sepsis pathway as soon as possible. So again, about answering the bleep, it's important that this is responded to really quickly. Often the junior doctors will be asked to speed along the discharges of the women on Folkestone ward, because very often we're at full capacity, pushed for beds, and we like to escalate and discharge as soon as possible. Not only is it inconvenient for the patient waiting around for either TTOs to go home or to be deemed fit from the junior doctor, for us, on the point of safety, we often have to escalate and move things along. So it's really important to keep the flow of patients coming through the unit.
Doctors in training stay with us anywhere between 4 months to a year. So depending on their level of training, they will be doing a combination of clinical work where they will be exposed to both obstetrics and gynecology, and will have plenty of opportunities to have their work-based assessments done, and also physically learn about both obstetrics and gynecology. One of those opportunities will be while you're working clinically, where they will have ward-based teaching. So if you're, for example, if you're doing a ward round with a consultant, it's a very good opportunity to present your cases and get one of your work-based assessments done. We also have a dedicated teaching training sessions on various days of the week. One of them would be a GP teaching session on a Tuesday afternoon. Again, you're welcome to present your cases, or it will be just a topic teaching from either myself or one of my colleagues. Dedicated bleep-free teaching session goes on for specialty trainees on a Friday afternoon, which is fully curriculum mapped. Although this is a very busy unit and you will have very heavy workload, you will be continually supported and assessed throughout. So if you have any issues that you're not sure about or you are worried about, please come and find any of us. We are all here to help you, and we will support you throughout.
When you join the department, you will be allocated to an educational supervisor who will look after your educational needs for the time that you're with us. So part of that involves your ongoing assessment aligned with the RCOG curriculum, and you can find more information about that on the RCOG website. However, day to day you will be looked after by a clinical supervisor, and that will generally be the consultant that you're on call with. If you have any clinical supervision concerns, you should immediately escalate them to the clinical supervisor that day, so the consultant on call. Or if there are other educational concerns that you have, then these should be raised at one of your educational meetings. You should meet with your educational supervisor ideally within a week of starting in the department, and then you will meet at least 3 further times during that year. They will review your portfolio of evidence, and it's very much a curriculum that's driven by you as the trainee. So we will go through your portfolio of evidence with you, and we will talk to you about where you are going next and what you have to achieve in order to get the ARCP outcome that we want you to achieve. It's a very busy clinical environment, but with that comes lots of opportunity for you to develop your technical and non-technical skills training whilst you're with us. So for example, we run a theatre list almost every day, and you will be rostered and have opportunity to go and assist or lead surgery depending on your stage of training. Whilst on call, there will be lots of opportunity for you to see semi-elective work and also emergency work, and develop the skills that are matched to you at your stage of your curricular and training. So for example, if you're one of our GP trainees or foundation doctors or ST1 to 2 doctors, then it's likely that you will be assisting initially in caesarean sections or instrumental deliveries or complex repairs in theatre. However, as you then progress as an ST1 to 2, you would be encouraged then to start doing caesarean section under direct supervision, for example. If you're a senior trainee, then there are other opportunities for you to develop, and some of you will be starting to undertake advanced training and think about those within your career progression, and you'll be encouraged to develop that plan with your educational supervisor particularly. When you're on the shop floor, you need to communicate those plans with whichever clinical supervisor is looking after you that day, whether they're supervising you indirectly or directly, and make clear to them that what are learning objectives you're setting that day for you and what you want to get out of that shift. Having been through the UK training system for Obs and Gynae, my core piece of advice for you is to be proactive in your learning. Seek out opportunities. Even on a busy shift, there will always be an opportunity for learning. You need to speak early to the clinical supervisors or your educational supervisor, and be creative about the way that you seek out those learning opportunities. No 2 days are the same. We might deliver 10 babies in a day, but each of those will be unique to that family and unique to us, and a unique part of their experience. Likewise, being able to develop the skills to support a woman through a pregnancy loss or another traumatic experience in pregnancy is something which you can get good satisfaction from, knowing that you've supported this woman through something that can be very, very hard for her and her family to cope with.
It is a busy unit where you will be asked to do various things all at once, but take one thing at a time, and if you're not able to manage, just let one of us know and we are here to support you.
Come with a smile on your face, always expect a cup of tea, and certainly answer your bleep on time.
It's a new set of guidelines to get used to, it's a new way of working, new bleep system, door entry fobs, all those kind of things, as well as the usual clinical stuff that you have to deal with. So we can really support you and just get to know the midwives, get to know the midwives in your team, get to know the doctors in your team, because they've all been there and they do understand. You can come in to a fairly quiet day if you like, and you've got time for doing some learning and embedding your knowledge, but other days you can come in, hit the ground running and be straight into theatre because everything is going on, and that's what keeps it really interesting. So yes, welcome to the unit.